Okay. Thank you so much for having me. It's a pleasure to be back. So I'm here to talk about music therapy and how it works and how it functions, especially in my background with memory care. As Allison mentioned, I am the internship director and director of music therapy services at Silverado Beverly Place. We're one of the only locations and places that has a full-time music therapist on staff, which is really beneficial and great experience to be a part of. We work with memory care from all stages, from early onset all the way till late stages, including we have our own hospice services. We see our patients and our residents, we call them residents here, go through the whole process from start to finish, and we treat them along the way, which gives us a unique perspective and ability to provide services that is catered very specifically towards, the neurodegenerative process of dementia. A little bit about my background. I'm currently a PhD candidate at Colorado State University for music therapy, and my master's in public administration, which has translated well to me running an internship and establishing what we have here at Silverado. I'm a neurologic music therapist, which is a subspecialty of music therapy that focuses on how music and the brain function and the ability to improve outcomes through those processes and techniques. I'm a board certified music therapist, which is a requirement to be a music therapist. And I'm also a veteran, U.S. Navy veteran, military police. And I like to say that because it is a big reason why I became a music therapist, and it'll trickle in a little bit into this presentation from the concept of how music can even harm and things to be aware of with how music affects our body, and specific things that can come from that. I'm the director of music therapy internship here at Silverado Beverly Place, and I also co-own and am the internship director at Music Matters, which is a private practice for music therapy in Thousand Oaks, California. And so my background really focuses on trauma care, memory care, and neurologic music therapy. And I'm going to talk a little bit about how trauma care really is prevalent in memory care. It's a very expansive process that, with the neurodegenerative process, it can be very traumatic to the patients and residents that are going through it. So we see a lot of trauma care in this field. So we're going to talk about what music therapy is, the principles that govern us as music therapists and that are present in the functionality of music therapy, what neurologic music therapy is, and then we'll tie all of this into dementia and music therapy and specifically how we do things here at Silverado Beverly Place. I'm going to talk a little about interdisciplinary collaboration because my favorite part of this profession is working with other clinicians and kind of being part of a care team, and then talk a little bit about research. And I also like to share at the end, towards the end of the presentation, what music therapy inspired interventions people can take away from this. There's a lot we can do with music to heal and to be healthy. And there's a lot of things that people can do at home that aren't necessarily music therapy, but come from music therapy practice, but that anybody can do. And so I'll talk about my recommendations and how those can be effective. And then we'll have some time at the end for questions. So, what is music therapy? I get this question a lot. Specifically, music therapy, it's a clinical, evidence-based practice. We use musical interventions to accomplish individualized therapeutic goals. And a key component here is that they are non-musical in nature most of the time, the goals and objectives that we're focusing on. The music is the tool to get there. To be a board certified music therapist, it has to be approved by a AMTA music therapy program, which is our governing organization. Um, some of the domains we focus on: physical, emotional, cognitive, behavioral. You'll hear these show up in a couple parts of this presentation. And we're looking for intention, replication, and consistency. And this is something I tell my interns a lot. What separates a music therapist from a non-music therapist or just a musician is our ability to clinically take musical interventions, aspects of music, and apply them in such a way where we're intentionally replicating results for non-musical goals. So an example of this would be if we want to work on somebody's ability to grasp an object. Maybe they're a post-stroke patient and want to grab something. We're going to use rhythm, we're going to use entrainment, and we're going to work on motivation factors with music. And we're going to use these techniques that we know to help them work on grasping. We see higher outcomes when we implement music as a tool in this regard. And the ability of a music therapist to do this repetitively with knowledge is really what makes the difference between a music therapist and a non-music therapist. So to be a music therapist, you have to have a degree, bachelor's degree or higher in music therapy. There are master's and PhD programs as well. Um, After you do your degree, you have to complete To get your degree, actually, you can't even complete your degree without doing this part is a clinical training and internship phase. Now, in the education process, there's practicum hours that is required as well. So from day one, you're already getting your feet wet and working with clients and patients and learning the ropes of what music therapy is within the university. And then when you go to your internship, it's 1,200 hours, 6 months, 40 hours a week, full time. You are implementing all these techniques and skills that you learned in your education program, and you have to do that for about 6 months. And so all those hours accumulate. And when you complete your internship, you can take your board certification exam. Very rigorous test that every music therapist has to do to become a board certified music therapist. And then certain states might have specific requirements like licensure um, to go further to operate and to practice within that state. And that helps in lots of ways because in the insurance game, licensure often translates to being able to get your services approved by certain providers. So like states like New York, Pennsylvania have licensure, and they have the ability to do that. And then to maintain your music therapy designation, you have to do continuing education training every 5 years. You have to accumulate 100 hours of this, and then you can recertify as a music therapist every 5 years. And I think that's pretty standard in the clinical fields where the majority of PT, OT, doctors, neurologists, psychiatrists, everyone has to maintain these continuing education hours. So, music therapy principles. We're going to talk a little bit about what makes music therapy. I like to talk about the triangle. There's also the Venn diagram as well. Music, client, and therapist. All these three things need to be present for it to be considered music therapy. Obviously, music is a huge part of this because without it, we're not music therapists. So we have musical interventions that we use to achieve the outcomes that we're looking for with our clients. The therapist needs to be present to make it clinical and to implement this. And the most important aspect is the client. Without the client, we're not working towards anything. So our treatments are very much catered towards the client's specific needs. So all three of these must be present for it to be considered music therapy. And within those principles, we have some phrases and terms I'm going to share as you might hear this come up a little later. I'm going to talk about the container of music. So sessions are structured very specifically, again, with that intent that I talked about earlier. So there's the beginning, a middle, and an end, and transition points between each one. The middle is the crux of what we're doing. So the treatment plan would be present most likely in the middle section, but we ease our client from a baseline perspective into that middle section. And then the end section, we always find closure within every session. We always want to leave our clients in a better place than we started if possible. So we structure the sessions in such a way to gear towards that closure point. Within the session, we use things like entrainment to lock our clients into phase with ourselves and with the music interventions that we're doing. And this is something that most people have familiarity with, whether you have musical training or not. If you've ever been at the gym or a concert or with other like-minded people listening to music you like, you'll see that you tend to have you'll notice that you tend to have this ability to lock into phase with the music, even if you have no training. And people tend to lock in together, and they tend to enjoy that process. So that's entrainment. And then from a motivation perspective, music is a lot of fun for most people. Most of us have some kind of relationship with music, so we use that to encourage participation in the interventions. The interventions might not always be the most fun things in the world. Like we're asking you to hit a paddle drum because we want to work on exercise and it's exhausting. Even things like fine and gross motor skills can be a little bit repetitive. So we use music to try to make it as fun as we can. So it's an enjoyable process. That motivation is one of the most important aspects for getting people to actually consistently stay in therapy and work on the things that they need to work on. And then ISO principle is kind of our governing principle. It's one of the most important aspects of our philosophies. We always meet our client where they are at in the moment. This is very important. If our client is agitated and angry, we're going to meet them there. We're not going to try to provide a discrepancy. Discrepancies really are can be jarring and can discourage. So we're always trying to meet our clients where they are in the moment so that we have the most successful outcomes. And so the process of how we do music therapy from start to finish, there's a referral process. This can be self-referral. This can be from a family member. This can be from a music therapist. This can be from a neurologist, a psychiatrist, anybody will refer to a music therapist. Here in California, we get a lot of neurology prescriptions through NMT CPT codes. So we get all kinds of clinicians that are prescribing people music therapy. So these come from various sources. Once the client has reached out to the music therapist through a referral process, we would conduct an assessment. An assessment is a very in-depth procedure that we do to find out baseline material. So we want to know where they are now and where do we need to go from here. Now, that assessment can be anywhere from 1 to 3 sessions, but I'd like to always point out when I talk about assessments, it never ends. Assessing is something we're doing 24/7, the whole process, but we do need to find out a starting point. So that's where we do our initial assessment, and then we will build a treatment plan on that assessment. Anything in the treatment plan cannot be in there unless it's in the assessment. So that's what the importance of the assessment as well, is it informs us what's needed. Sometimes, and a lot of music therapists know this life where we don't get that much background information. It depends if we're working with a care team. If we're working with self-referral, there's oftentimes not that much we get, and we have to kind of go from scratch and figure it out ourselves through observation. So we do the best we can with the information provided, and then we build a treatment plan from there. So in that treatment plan, we will create goals and objectives. Goals are very broad things that we're going to work on. Those are those domain areas that I talked about earlier, like cognitive, ambulation, fine and gross motor skills, things like that. And objectives are very specific. Like the client will do A, B, and C for a certain amount of time throughout this process. And I have some examples of those later in the presentation. So then we will implement those interventions for step 4, and that's the process of therapy that goes on for however long it needs to go. It could be 3 months, it could be 6 months, it could be a year, it could be 5 years. That's that intervention implementation. And throughout this process, since we are constantly assessing, we evaluate and we reevaluate and we make the changes that are needed to increase the success of our clients. We are always catering this treatment plan specifically to the individual. Nobody's treatment plans are ever exactly the same. So it's a very catered individual thing. And we are constantly making changes based on strengths and needs to really amplify the ability of the client to be successful where they need to be successful. And then part of step 5, it's not listed here, is termination. In many cases, therapy will end, and therapy is meant to end in a lot of situations. If the client meets their goals and objectives and there's nothing else to necessarily work on, then we'll terminate services. If the client wants to continue even though they've met those goals and objectives, we call that maintenance, and that's fine, but that's something that the client needs to sign on to. They would understand that we're just trying to stay stagnant here and keep it. So in many of these processes, termination is the conclusion of that service. So something I like to talk about with music, can music harm? And this is something that a lot of people have different perspectives on, but overall, music can harm in various ways, both physiologically and psychologically. And we'll talk about some of those ways. An example, and this from my background, veterans with PTSD, sharp staccato drumming. This can trigger hyperarousal, can trigger flashbacks. It sounds like gunfire to veterans. So something we have to be aware of. And this is something that has triggered me in the past, but it's also been something that I've seen in groups that I've done with veterans, combat veterans, where, yeah, like those snare drum sounds can really set a trigger for them and bring them back to a place that they might not want to be in that moment. So we have to be very cognizant of that and understand the clients that we're working with. Unpredictable tempo, volume changes. This can overwhelm the nervous system. We get overstimulated. We see this a lot with kids and adults on the spectrum. So we have to be very careful of the sound that we're projecting with our clients. Loud music can lead to sensory overstimulation, dysregulation, parts similarly. And again, many populations this can be effective. This can be very effective on neurotypical people in a concert where the volume is just too loud and we feel it in every part of our body and it's just not a good feeling. It can overwhelm our eardrums, could overwhelm many of our processes. So something to keep in mind. And music and memory can invoke scenes and experiences from the past. Music and memory go like this. So there's a lot of coding and association that we have with certain parts of our lives and the music that was involved there. So something to be aware of that when we're using music as a tool for therapeutic purposes. So some of the different types of interventions we use. Um, Passive listening and act so what this is where the client is listening to the music but not necessarily participating in the musical process. So this is like listening to a song and maybe talking about the lyrics later. It would be a example of passive music therapy. And active music therapy is where the client is actively participating in the music making of the intervention, playing the drums and then for stress relief purposes. Improvisation is in the moment, being present, processing, and using music in an improvisational manner. And something I talk with my clients a lot when I hear this all the time that I can't improvise, I'm not a musician. When we have a dialogue, when we have a conversation, we're improvising. Everybody has improvisation skills. That can very well be translated onto a single tone instrument like a drum, where you just play whatever you feel. It doesn't matter. There's no wrong way to do it. And so we use these skills to encourage that improvisation because it's very healthy for our self-expression. And we can create things in the moment that we never thought we could. So we use this as a tool in a lot of drumming sessions and a lot of even just lyric analysis sessions when we're having discussion. And then composition. A lot of people will come up with their own lyrics, their own songs, their own creations. We like to record them when they do, and so they have those records of it. And we use piggybacks and things like songs they know, fill in the blank, right? You don't have to be a songwriter to help change a song to reflect how you're feeling in the moment. So these are examples of interventions we use. So subspecialty of music therapy, neurologic music therapy. It's a very clinical side of music therapy. It's very well respected within the field and within the clinical service field in general. Many people know about neurologic music therapy. It is the most thoroughly researched component of music therapy out there. Run by the Neurologic Music Therapy Academy, and they have like thousands of studies they've done. So to be a neurologic music therapist, you have to take a course that's about a week. It's like every day in a week. And then after you pass their exam, you can be called a neurologic music therapist through their organization. You have to be a music therapist to be a neurologic music therapist, but you don't have to be a music therapist to take their course, which is something really cool. A lot of neurologists and other clinicians will take this course, but you can't get their designator unless you are a music therapist first. And so they've developed these systems using musical elements from melody, rhythm, timbre, dynamics, and tempo to create techniques that focus on neural pathway development. How can the brain be improved by musical outcomes? How can we use music to affect the brain in very specific ways that we know how to replicate in certain situations? And so a lot of this has to do with neuroplasticity, cognitive behavior function. So how can we stimulate the brain? A lot of this comes from PTOT. So a lot of collaboration with physical and occupational therapists when these techniques were being developed. So the neuroscience here is how the specific elements can change the nervous system and how and through this process. And there are 20 standardized clinical techniques that have been developed through neurologic music therapy for very specific cases, and that's how they're implemented. I'm going to talk about four of the 20 because we'll be here all day if we talk about 20 of the 20. These are some of the ones that you see a lot. If you type in neurologic music therapy in Google, you'll see cases that are very high profile, and these are the techniques that are very frequently used. Rhythmic auditory stimulation. This is for this can be used with a lot of aspects, but mostly a walking gait, helping patients post-stroke walk again. A lot of big cases where this has been used. So innately, and we talked about entrainment earlier, we are intrinsically rhythmic. And so we use the combination of the auditory cortex and the motor cortex to sync up to encourage the motor cortex to refunction and to build neural pathways for movement. Um, Another one is therapeutic instrumental music performance, TIMP is what we call it. And the first one, RAS, is another, that's our term for it. And this is where we use paddle drums, instruments that a client or patient can reach out to and play to encourage movement. A lot of motivation factor in here. We use this for rehabilitation of injuries for lower extremities, upper extremities. RAS is really focused on walking gait. TIMP is focused on any mechanical movement. So we look at those techniques for that. Melodic intonation therapy is probably one of the most famous for neurologic music therapy. This was the technique that was used with the Gabby Giffords incident where she was shot in the head and she couldn't speak. So they used this for expressive aphasia to rehabilitate. The ability to sing is usually intact, depends on how your brain injury functions. But for the most part, especially if you have Broca's aphasia, we see high success there. Your ability to sing and intonate is safe, and your ability to speak is not. So you can sing, but you can't speak. And so they discovered this, the care team that was working with Gabby Giffords on accident. So they brought in a neurologic music therapist, and within 1 year, they worked with her to be able to speak again. They taught her to sing what she wanted to say with rhythm. I believe the first word she was able to say was water. So they took bongos and broke the syllables up, dut, 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 dut. And then they added intonation, la, 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 la. And then they brought in the word water, water. And over time, they built up the ability to speak sentences with rhythm, singing, intonation. I want some water. And then they taught her to take out the music so she could say it. Now, she always has a cadence. If you ever hear her speak on YouTube, you'll hear that cadence. But they basically use the ability to sing to teach her to speak again. So, this is one of the most effective techniques you'll find within the NMT, or at least high profile, I should say. They're all very effective. And then pattern sensory enhancement, rhythmic, melodic, harmonic, and dynamic acoustic elements of music provide cueing for movement, which reflect functional exercise of activities of daily living. Now, number four and number two, TIMP and PSE, very similar. What's the difference? PSE uses cueing that you build in classical conditioning and then you take it out later. TIMP, it doesn't do that. So there are musical cues in all of this, but we're not specifically building that cue in permanently and then having to deprogram. So that's the difference between number two and number four. So NIH put a really cool tool for music therapists, for really anyone that wants to understand how music affects the brain from a clinical perspective. And you can look this up. It's very comprehensive. So it's the music-based intervention toolkit, how specific elements of music are affecting your brain so we know which areas to work on and what techniques will be successful most likely. And they have it all color coded and it goes way more in depth online. This is just a snapshot of it. So I highly recommend if you're interested in this to take a look at the NIH Intervention Toolkit. I'll talk about some components of it here. Auditory motor, and that's where rhythmic auditory stimulation comes in. We just talked about a little while ago. Steady beat synchronizes gait and movement, auditory timing cues to motor planning network. So all of this is very spelled out, research driven. You can see the sources that they use to build these diagrams. So it goes through everything: auditory limbic, somatic motor, visceral motor, acoustically active vestibular. And all of them play a role together. It's not just two sections of the brain. That's something that I always like to specify. Your whole brain is active on music, but there are very specific parts of your brain that we can focus on with specific things to focus on what a client's goals and objectives might be. So talk a little bit about dementia and how music therapy comes applies here. It's a general term, refers to the impairment of memory, cognitive function, and decision making. It's more prevalent in age 65 and over, although we're definitely seeing that age lowering. Research shows an increase of dementia amongst younger populations. I think a lot of the stats are now 55 and over. Dementia can occur in any demographic, and by 2060, 14 million adults in the US will have some form of dementia. Currently, there is no cure. And I think recently the stat changed to like one in four over the age of 65 will have dementia. So it is a ever-growing issue to be addressed. Different types of dementia. Lewy body dementia is about 10 to 15%. Abnormal protein deposits in the brain. Vascular dementia, blood vessel damage, 10 to 15%. Mixed or unspecified kind of makes up the rest. Alzheimer's is the most common, 60 to 80%. Most common is degenerative. And frontal temporal is a early onset, very fast-paced dementia, changes in behavior, personality, and language. So music therapy within this setting, things we're looking to do increase. So these are domains, goals, and some of them objectives, right? Increase participation and attention span, improvements in communication, socialization, increase ambulation and walking gait. That's more of that neurologic music therapy side of things. Increases in cognition, and yes, we do see improvements in cognition. So it's a philosophy of Silverado I really respect in this field. There are a lot of memory care communities and companies out there, but Silverado really focuses on taking research and what the data is saying and applying it into practice for care. And we see a lot of our residents come in and improve before they start declining. I mean, inevitably it's neurodegenerative, but that doesn't mean that in a short amount of time you can't make improvements, and we can definitely slow the progression of the disease down significantly. Many of our residents here are here for 6, 7, 8 years because they participate in our brain health programs. So we do see increases in cognition, improvements in mood and emotional processing, and improvements in quality of life. So we take a person-centered humanistic approach, and the big mantra here is love is greater than fear. In our um, clinical team, caregiving and engagement, structured like PTOT. This is how the music therapy approach is here. We are geared towards improving cognitive function, language and memory recall, maintaining social skills, providing quality of life. So we also open our music therapy group specifically to staff members. So not just our residents are part of it, everybody's a part of it. And that communal aspect really does encourage our residents to participate. And so we're looking to address anxiety, depression, agitation, aggression, isolation, different various behaviors. We are very lucky and blessed to have an interdisciplinary team here, and we all work together. So we get to work with music therapy and physical therapy, occupational therapy, speech language pathology, neurology, nursing, and caregiving. And so we all come together and we co-treat. And we shape the things that we do here to include the other disciplines so that we really can increase the outcomes for our patients, our clients. Um, a bunch of different tools in the toolbox. It's very important to have different facets on how we're approaching our care. So I'm going to talk about a specific resident and share a video of this specific resident, as well as the goals and objectives that were being worked on. Um, we're going to refer to this person as JW. Consent was given to share clinical goals and objectives and the footage, but we were asked just to keep the name out. So this person is 66 years old, musician, diagnosed with Alzheimer's in 2019, struggles with anxiety, emotional expression, ambulation of his left knee. Recommended for music therapy one-on-one, so one music therapist, one client, and co-treat with PTOT, which we call two-on-one, which is two clinicians and the client, and increasing emotional expression, reducing anxiety, and increasing balance, gait, knee strength were the goals of this particular session. And so what those look like is goal one, to increase walking gait and balance. So that would be the broad goal, the domain. And the objective is during a 45-minute two-on-one, two clinicians, one PT, one music therapy, or one OT, one music therapy session focusing on increasing balance. The resident will balance and walk unassisted in time with the rhythm of the drum or guitar provided by the music therapist for at least 3 minutes throughout the co-facilitated session. And then goal two, to increase knee strength during a 45-minute two-on-one session, focusing on increasing knee strength. The resident will kick a tambourine drum assisted by PT in time and rhythm to the music provided by the music therapist for at least 3 minutes throughout the co-facilitated session. And so this is JW.
She'll be coming round the mountain. She'll be coming round the mountain. She'll be coming round the mountain when she comes. Nice harmony.
That sounds pretty good.
It does sound really
Yeah.
good. How you feeling?
Good.
Yeah, tell me about it.
I just feel free.
Free.
Yeah.
It's a good feeling.
Yeah.
So lots of parts of that video that we talked about earlier. You'll notice that the auditory engagement, the entrainment that JW is doing with his vocal intonation, he was singing melody while syncing up his ability to walk, kick out, play the paddle drum. That's rhythmic auditory simulation. That's the ability to sync up your auditory cortex with your motor cortex. Um, Lots of components of therapeutic instrumental music performance. You kicking the paddle drum. It's also that feedback they feel from kicking the paddle drum, feeling their foot hit that paddle drum in rhythm while encouraged with the music, and then the repetition of it. So all kinds of techniques were used in this treatment process to work on walking gait, balance, knee strength, things like that. So we have an internship here at Silverado. We take 8 interns a year in 4 cohorts. So every April, um, July, October, and January. Um, so two at a time, and they all do 6 months. So they overlap for a total of four at any given time. And they have to do 1,200 hours, 40 hours a week. They have a certain number of hours they have to do for clinical engagement, for administration, for paperwork, for documentation, for training. So while they're here, they're working in groups, they're working one-on-ones, their caseload, co-treat with PTOT and other disciplines. They will be working on documentation, assessments, treatment planning, intervention implementation, evaluation, interdisciplinary collaborations, and they culminate in a research case study where they pick an individual to work on. They write a whole hypothesis and research question and a case proposal, and then they will implement that and then report on it in a case study at the end of their internship, and that's their like graduation from the internship. So it's definitely very reminiscent of a resemblant, I should say, of a graduate level project because they're working on a living person. And Silverado really tries to stay at the forefront of music therapy research and just clinical research in general. So we're always looking at what works, how can we improve care for our people, what techniques can we try, and within the music therapy world, we're always looking at the new things that are coming out and how can we improve the craft. And so that leads me to a current collaboration that we're doing with USC, which is I think is really cool. Krikor Sarafian is our director of Select Rehab, and he's an occupational therapist who runs our PTOT team. And we're working with Dr. Tara Rose, who works in the neurology department over at USC, gerontology as well. And we are collaborating with how we can take PTOT and successfully sync it up with music therapy as an interdisciplinary team. The cool thing about this research is that we are doing this already. But now we're systematizing it in a way where we can report on it and create protocols that we can share with how this can be successful elsewhere. So that's kind of in the works right now. So some things I want to talk about music therapy inspired interventions that anybody can do outside of here. So some of the things we talked about, lyric analysis, songwriting, intentional playlisting, drumming, sing-along. So lyric analysis and songwriting. Anybody can take music that they enjoy, take a look at the lyrics and think about why those lyrics in that song has an effect on you as a person, what stands out to you, identifying those elements and themes, and then deciding what can be changed to really reflect an individual story. And that's where that songwriting component is. You don't need to know how to write a song to do this. You can cross out words and change things to make it your own. So this is something I always recommend. A very individual thing to do. Everyone's music's different, so it really has to be music that speaks to you. And then intentional playlisting builds on this. Again, everybody's music is their own, the things that they like, and that's what makes this effective. Having playlists to kind of drive your emotions is very powerful. When we listen to music, it has this effect on us, both psychologically and physiologically, and it affects our emotions. And so, if we can use this, harness this in a way where we can change our emotional state, that's a powerful tool. Now, we do this anyway, often when we're feeling really sad and we want to listen to a sad song because it's meeting us where we're at, and that's important and valuable. So with intentional playlisting, you can start from one place and go to another. The goal is to go from point A to point B. But you have to do this very systematically, and it has to be songs that mean something. So everyone would have to create this for themselves. I myself have like 30 playlists, and they don't just go from one polar opposite emotion to another. I would never say, hey, let's go from anger to happiness. That's so polar opposite. It takes a lot to get there. So you maybe want to go from angry to less angry or frustrated to less frustrated. You want to meet yourself and honor what emotion you're feeling now. You want to meet yourself where you're at, but then you can take yourself to a new place. And over time, this gets more efficient, especially if you like cater and hone your playlist in such a way where it's really effective. Drumming is so healthy for us, and it's fun, and it's exercise, and it's stress relieving. And by the time you're done drumming, most people forget the problems that they're having to begin with, for at least for a short amount of time. We do a lot of drumming sessions where we talk about stress. And we're like, let it all out on the drum. And by the time we're done, everyone's like, wow, I feel so much better. It's such a release. The cool thing with drums is accessible to anybody. Anybody can drum. And single tone, small drums are not expensive. So this is something that can be really accessible. I always tell people too, pots and pans are most people have them, so that's free and they're great things to drum on. Sing-alongs, we do this anyway. Many sing in the shower, many sing in the car, many sing along to songs they like. You're in training to music and you're syncing up with a song that means something to you. And a lot of reasons why songwriters put music out is to connect with people. So even though it's a recording, we do feel connection, especially when the themes of that song sync up with the themes of our life. So another healthy way to incorporate music into your life in a therapeutic manner. So some resources if you're interested in music therapy and want to know more. The American Music Therapy Association, AMTA, is our governing organization. And then the Certification Board for Music Therapists, CBMT, is the governing organization that manages our certification, our board certification. Both have a lot of expansive information out there, and studies and research as well. Neurologic Music Therapy Academy is the governing organization for NMT, and they always are happy to put people in the right direction of areas that they're interested. If you have a question about how the brain processes work, they will answer it for you. If you want to get connected with the neurologic music therapist, they will do that for you. So good resource to look at. And then the Journal of Music Therapy, JMT, is our peer-reviewed research-driven journal. There's a lot of research in these journals for the last, I'd say, like 50 years, but there are many music therapy research sources out there that aren't part of JMT. A lot of people have done it. NMT, for example, has done a lot of their own. So a lot of research out there that I encourage anyone that's interested to take a look at. And my references for the things we discussed today. And I really appreciate you taking the time to listen to me and to be here. I'm going to open the floor now for questions or comments. So if anybody has anything, please feel free to share.